Good afternoon and welcome everyone to today's webinar, kicking off Spiritual Care Week, 20 highlights from spiritual care research. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Just some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio visual, please type those into the chat box located into the platform's dashboard. You will also notice a questions pane in that same dashboard. You're welcome to send us questions at any time during the event. We're going to gather those at the end and then present them to our panelists. One thing I'd like to bring to your attention, though, we attached a handout, which is the actual highlights for this presentation, which has all the citations, all the abstracts, and what have you. So I encourage you to download that, again, anytime during the event. And with that, I'd like to turn it over to George Fitchett, the Transforming Chaplaincy Director. George?
Thanks, Andy. Hello and happy Spiritual Care Week. Spiritual Care Week is a time to acknowledge and celebrate your important contributions to the health, the well-being, the comfort, and the peace of all the patients and families and staff that you serve every day. As this year's theme for Spiritual Care Week reminds us, research plays an important role in describing and strengthening your spiritual care. And here at Transforming Chaplaincy, we're pleased to provide you with resources to help you celebrate Spiritual Care Week. Andy, let's advance the slides to the list here. Part of what we're providing you with are 5 webinars about spiritual care research, one for each day of this week, Spiritual Care Week. And here you can see the list of the webinars, you can see their times, and we invite you to join us. In case you miss any of them, the videos will all be saved and they'll be available on the Transforming Chaplaincy website. Also, be sure to check out our short video of our colleagues who are describing why spiritual care research is important to them. We're sure that you'll enjoy that. And now I want to introduce the presenters for today's webinar. Paul Galchutt is a research staff chaplain, convener of the Hospice and Palliative Spiritual Care Research Network for Transforming Chaplaincy. Paul is the instructor for Transforming Chaplaincy's Research Literacy 101 class and also an instructor in the California State University Palliative Care course. So Paul, thanks for being with us. And let me also now introduce Shelley Varner-Perez. Shelley is a Senior Program Manager for Spiritual Care and Research and Affiliated Research Scientist. She co-teaches Transforming Chaplaincy's Research Literacy 102, and as many of you will know, she's one of the co-facilitators of the APC Webinar Journal Club. Shelley comes to us from IU Health in Indianapolis. Paul comes to us from mHealth Fairview, University of Minnesota in the Twin Cities. And Shelley, I think I'm going to turn it over to you.
Thank you, George. Appreciate it. So we are very excited to share with you these 20 highlights and want to give kudos to the Transforming Chaplaincy fellow graduates for their contributions to these highlights, and of course, George's very important work compiling these. So highlight number 1, you can proceed to the next slide, Paul. Religion and spirituality is one of the most important resources for coping with serious physical illness. There is consistent evidence that religious and spiritual beliefs are among the most important resources for coping with serious or chronic illness. This evidence continues to build over time. So for instance, in 2013, Canada and colleagues found that among nearly 9,000 cancer survivors, half described faith as helping them very much, and an additional 18% described it as helping quite a bit. As displayed in figure 1 here from the Canada study, on the grouping on the far left, the importance of faith was higher for Black and Hispanic patients than for white patients. There are similar findings from other studies. For example, among 230 patients with advanced cancer whose disease was not responding to treatment, 68% reported that religion was very important, and an additional 20% said it was somewhat important. 12% said religion was not important. That's from the Balboni study. In a recent study of 325 Latin American patients with advanced cancer, 315, that's 97%, considered themselves spiritual, and 89% considered themselves religious. In this study, when asked to rate the importance of religion and spirituality on a 0 to 10 scale, more than half the participants related it as 10. Paul, on to you for highlight number 2.
On to 2. Thanks. It kind of feels like we're doing a little bit of a little bit older than you, but that top 40 or top little bit of this countdown list. So as the drum roll gets a little bit louder, let's move on to number 2. So in addition to physical illness, religion and spirituality is one of those most important resources for coping with serious mental illness. I want to report on 2 studies that were highlighted here. The first is a review done by Milner and team in 2019. And among the 38 qualitative studies, pretty big number, they culled out 4 select themes that we want to highlight here for us. So whether you are in a more medical surgical environment or whether you're dedicated more to mental behavioral illness, these certainly apply because this affects and relates to all of our work. So identity, spiritual practices, spiritual relationship, and certainly religious struggles. And I like how they highlight among the spiritual struggles there at the bottom, guilt, feelings, the stigma, that's really important. And then additionally, I want to mention that the study from Joe Currier and team published in 2019 focused on an inpatient treatment program that was spiritually integrated, that 39% of those that were hospitalized reported religious faith was moderately or quite a bit important to them, and that above that, an additional 24%, it was extremely important. So if you're doing that math, up to 2/3 of the people reported that religion and spirituality was important for them in their inpatient program. Moving on, Shelley.
Yes, to highlight number 3. Next slide. Religion and spirituality play an important role in helping family caregivers of patients with serious illness. Patients value support chaplains provide to their loved ones. Next slide. So just as religion and spirituality play an important role in the lives of patients with serious illness, so too religion and spirituality are important for caregivers of patients with serious illness. So in this first study of 156 caregivers of patients with ALS or advanced GI cancer, 87% of those caregivers reported religion as very or somewhat important. In the same study by Asano and colleagues, as you'll see there in table 3 on the right, nearly 1/3 of the caregivers reported feeling abandoned by God, and Paul helpfully circled that in the red. Feeling this way was associated with higher levels of depressive symptoms, and we'll say more about this in highlights number 4 and number 5. Other studies also describe the importance of religion and spirituality to caregivers. So one of these is a study of 43 caregivers of patients with advanced cancer, in which 100%, all of them, reported religion and spirituality as a source of strength and a source of comfort, and that it helped them cope with their loved one's illness. And then the third study that we're highlighting, just about 1,600 patients returned a survey about their expectations of chaplains. And 71% rated chaplains offering support to family and to friends as important or very important. This is Kate Peterman's study from 2010. And we'll have more information about this study in highlight number 6. Paul, back to you.
Thanks, Shelley. All right, friends, I hope you're enjoying these pictures. They came from my trip to Glacier National Park. For those of us who like the data, it's important, but we thought we'd just insert some picturesque slides in the meantime, just to give a little gap between the data to give a more sublime grand view of things. So number 4. Oops, I'm just kind of moving my screen here in front of me. That while religion and spirituality are important for coping, some patients also experience religious, spiritual distress or pain. And as Shelley had mentioned, Dr. Marvin Delgado-Guay gets a decent amount of press here in these highlights. He does some incredible work with colleagues down at MD Anderson Cancer Center. So as you can see from this study that is highlighted from 2016, from that cancer center, spiritual pain. And spiritual pain for them is a pain deep in my soul that is not physical. That's how they define it, and use that as definitional for this process, and use that on a scale from 1 to 10. And with this study of nearly 300 outpatients with advanced cancer, and again, when we say advanced cancer, these are people who have limited treatment options and may not be facing the possibility of cure. 4 was the average rating, and for people who had below that number, considered to have no spiritual pain. So 57% were that number, but it's noteworthy to mention that 43% had some identifiable spiritual pain. As you can see, 22% indicated mild, and that those who had moderate or severe, it was at 21%, which for me on any given day, when I used to be in outpatient cancer care in an advanced cancer infusion clinic, it was about 100 people. So that's a lot of people on any given day showing up who have and are experiencing this. So they also found, I think it's important to note, that with those who had any reported spiritual pain, there was a 3-time likelihood that that pain would endure over time. And that's an important finding as well. In a paper that was published recently in the Journal of Pain and Symptom Management, done with work with Annalika Dahm and team, they focused on religious spiritual struggle using 331 outpatients with 6 cancer centers and having a patient population of 55 years or older. They found these findings, which really stand out, that 66% of patients had some religious spiritual struggle. About 20% indicated that with that, they had quite a bit or a great deal of struggle on at least one of those religious spiritual struggle items. Some of those items that are listed here, the 4 with the greatest or higher proportions, were felt guilty for not living up to my moral standards, felt troubled by doubts or questions about religion or spirituality, felt angry at God, and 4th, questioned whether life really matters. Next. Let's keep this flowing.
Number 5. So what about spiritual pain? Why is it important that we know about it? It's important to address religious and spiritual distress or pain because evidence shows it is harmful to physical and emotional health behavior, and quality of life. So there is strong and consistent body of research that finds higher levels of religious and spiritual struggles are associated with poorer health outcomes. One of the earliest of these studies examined religious and spiritual struggles in a sample of 96 medical rehabilitation patients. That is, patients with joint replacements, amputations, and stroke. This study is an oldie and a goodie by Fichette from 1999, Fichette and team. Among these patients, higher levels of religious and spiritual struggles were associated with poorer rehabilitation outcomes at their follow-up, which was at 4 months. Anger with God was one of these religious and spiritual struggle items in the study. And so what you see here is that item, figure 1 from this study by Fichette and colleagues, that while few patients reported any anger with God, you can see circled in green, 6 patients reported anger with God. Those who did had poorer recovery of their activities of daily living, their ADLs, compared to those who did not report any anger with God. So one way that religious and spiritual struggles may be harmful is by reducing the motivation to adhere to recommended treatment. We also are going to look at here a study of adolescents, 45 adolescents with cystic fibrosis, who found that higher levels of religious and spiritual struggles were associated with poorer adherence to recommended airway clearance activities. That's Grossame and team from 2016. Adherence to these activities is important in slowing the disease progression. So we have some important information here from medical rehab and also from adolescents. And back to you, Paul.
Thanks, Shelley. All right, friends, we're at number 6. And if you have a glass, I invite you to raise it for this next highlight. It's pretty exciting data. So a substantial majority of hospitalized patients tell us that they want spiritual care. So in a study mentioned earlier by Shelley in a slide was the study that was done by Dr. Kate Peterman and her team at the Mayo Clinic, which I'm in Minneapolis, so just south of us here in the good old Rochester area, but it also included where the Mayo Clinic is in Jacksonville and Arizona. So in this slide of almost nearly 1,600 respondents, back when we used to do more of those mail-in surveys, 70% wanted, as Shelley had said earlier, at least one chaplain visit during their hospital stay. And I don't know about you, seeing 70% of the patients, staffing ratios at most inpatient hospitals, I'm guessing don't match being able to do that. They also found that more than a third wanted a chaplain every few days, and that 1 in 5 chaplains wanted a daily chaplain visit. Some history rolls on, 10 years plus later. This study is replicated by a group of colleagues led by Beth Muehlhausen and team through Ascension. They interviewed people. So instead of waiting for people to perhaps be home and fill out this mail-in survey and do some recall, there was people in real time doing these interviews with patients and the possibility of their loved one caregiver family members. So as you can see here, 292 total sample, and among them, the family members totaled 160 for that N. If you had a mic, I think this is where we drop it. 93% of the patients and families a part of this study identified that they wanted at least one chaplain visit while they were in the hospital. I think that's just kind of like worth a pause. And among those with no religious preference identified, still just over 8 out of 10 of them said they still wanted at least one chaplain visit during their inpatient admission. If you are tuning into all of our webinars all week long, you'll be happy to know that Beth Muehlhausen will be presenting in more detail on this study on Friday of this week. Shelley.
Yes, Paul. Number 7, lucky number 7. So we are moving on to some clinical practice guidelines and what those tell us about religious and spiritual care. So important clinical practice guidelines recommend attention to patient and caregiver religious and spiritual concerns. On to the next slide. This is important for how we talk to our interprofessional colleagues. So guidelines for clinical practice in several clinical areas recommend spiritual assessment and spiritual care. The importance of attending to religious and spiritual concerns and palliative care in particular is widely recognized in practice guidelines. Those are the National Consensus Project for Quality Palliative Care, this citation 2018. So in addition to palliative care, guidelines for ICU care for infants and children and adults from the American Academy of Critical Care Medicine recommend spiritual assessment and spiritual care. And these guidelines really note the limited evidence for those recommendations and suggest that we need to do more work. Further research testing of the impact of a spiritual care provider on patient and family outcomes is needed. The best method for provision of spiritual support has not yet been studied and warrants further investigation. I will say that all of us during Spiritual Care Week probably have a hunch about the best methods or the best deliverer of this spiritual care, certainly in partnership with our spiritual care generalist colleagues. So since 2015, also the Commission on Cancer has recommended routine distress screening for cancer patients. This includes screening for spiritual distress as well. And what we have here is a systematic review of the literature in which it has been recommended by Robert and team that spiritual assessment and spiritual care be included as the standard of care in pediatric oncology. So Paul, you can have the mic drops all you want, but recommending that spiritual assessment and spiritual care be included as the standard of care in pediatric oncology, that one is pause-worthy. And now number 8.
I can pick up that mic from here. All right, moving on to number 8. So you've already heard that, I'm just gonna move my little guide thing around here. I don't know, I guess if we're kind of baking a cake here, we've got some important ingredients, which include these guidelines. We've already learned of the importance of religion and spirituality to patients and their family caregivers. But we also know that patient and caregiver spiritual concerns are frequently overlooked by healthcare professionals. So if I had a book of these studies, this is probably the one on the left that would be most thumbed, most identified, most page worn. A lot of us love to refer to the study done by Dr. Natalie Ernkoff and team back in 2015 in JAMA. Dr. Unkoff's now at the RAND Corporation, a part of their group doing research. I guess we could drop the mic a second time because this has some staggering implications, I think, for as all of us generalists, and as you identified, Shelley, within that palliative care model specialist, spiritual care provider, chaplain crowd. So what they found, that with 13 intensive care units across the United States, there were 249 goals of care conversations that occurred, they were transcribed, and that data was analyzed. Less than 20% of these care conferences had any mention of religion or spirituality in them. 8 of those care conferences had addressed or sought those considerations for those surrogate beliefs as they talked about their loved ones. And it's also important to note that among, again, the 249 goals of care conversations that occurred, only 2 involved chaplaincy staff members being in attendance. Additionally, this is kind of a meaty slide, so forgive me, Shelley, if I go just a little bit over on this one. Dr. Tracy Balboni gets mentioned again here in this 2007 study that among these 230 outpatients with advanced cancer, 7 out of 10 reported their spiritual needs were met minimally or not at all by the team. And also it's important that just under 50% of them said their spiritual needs were met minimally or not at all by their own faith community. And then recently, this past year, Dr. Marvin Delgado-Guy gets another mention in the Journal of Pain and Symptom Management with 325 Latin American patients with advanced cancer. 60% reported that their needs had not been supported by the medical team, their spiritual needs, religious needs. And then also, this is really important for those of us who like to keep track of how many chaplains are on a palliative care team, if at all, and then to what degree of the FTE are they dedicated on that. So some of the best and only data that we have on this comes from the study in 2016 with 410 US palliative care programs that identified just under 2 out of 5 had funded dedicated chaplain positions. On to you, Shelley.
Oh, number 9, and Paul set me up so good for this one. We need to talk about some satisfaction. So we have the Rolling Stones. I can't get no. Yes, we have to go there. So the Rolling Stones started us off with their song Satisfaction. Receiving spiritual care improves patient satisfaction with hospital care. There is a growing body of research indicating that patients who receive spiritual care report higher levels of satisfaction with their hospital experience in general. You can go to the next slide, Paul. And we have Deb Marin, who has from Mount Sinai, who has started us off with this research. She'll be the second author that I speak about. First, we're going to back up and talk about Williams and team from 2011. Those investigators surveyed over 3,000 general medicine patients a month after their hospital stay. They asked if the patients had any religious or spiritual concerns during their stay, and if those concerns had been discussed. So in the table below, among both patients who did and did not report having religious and spiritual concerns, if their concerns had been addressed, they reported notably higher levels of satisfaction with their hospital experience, including such things as overall satisfaction, satisfaction with their physician's care, and confidence in their physicians. Important to note from this table excerpt here, the reference group is those who did not report having a discussion of their religious and spiritual concerns. And if you're looking here at these odds ratios here, the values above 1.0 demonstrate increased satisfaction and are observed across all categories. Now on to the study by Marin and colleagues from 2015 that I mentioned a moment earlier. That study was conducted between late 2011 and spring 2013. They surveyed nearly 9,000 patients treated at Mount Sinai Medical Center in New York City, and those folks returned those satisfaction surveys. The investigators were then able to match the surveys back to the patient's electronic medical record, and specifically with indications in those records of any chaplain visit. They found that having had a chaplain visit was associated with higher scores on 6 key measures of patient satisfaction in the HCAP survey. Very important to be sharing with our administrators and executive leadership in our healthcare systems. On to you, Paul.
Shelley, I just have to give one more of those pauses because just to hear you sing the Rolling Stones. I see a red door and I just want to paint it black now. So I'll have you know the Stones actually were in the Minneapolis area last night doing a show. But
You're not a fan, I can tell.
Well, yeah, it's why I'm well rested that I wasn't there. And we're at number 10, friends. So representationally, this slide is not to be a rock in a hard place, because thankfully so much progress has been made, and thankfully due in large part to the Director of Transforming Chaplaincy, George Chat. This is really important. These 20 highlights, it's why I put a tie on today, but we're right in the middle of all these slides, so it's just a moment to savor, again, the lyrical tones from you, Shelley, with the Rolling Stones here. So we've mentioned Tracy Balboni a few times already, and she gets nods here because there's a couple of papers that we're going to mention from her and her team. Radiation oncologist involved in palliative care, medical school professor. She has done some important contributions for our field and continues to be involved both in the clinical aspects of that as well as contributing to the evidence base. So spiritual care is especially important for patients and families at the end of life. So in 2010, Dr. Balboni and team reported with a group of patients with advanced cancer the effects of spiritual care at the end of life. This gets quoted a lot because the findings really do stand out. That among those who received spiritual care from the healthcare team, which included chaplains, they reported a higher quality of life at the end of life. Additionally, this study group were more likely to have comfort focus, enroll in hospice, and were less likely to pursue non-beneficial treatments such as ICU admission or mechanical ventilation in that last week of life. Building on that study, Dr. Balboni and team, because they were less likely with this group to pursue those aggressive measures to receive comfort focused care in that last week of life, they crunched the numbers. And so patients whose spiritual needs were inadequately supported by the healthcare team, they estimated the higher cost of care in that last week of life on average was about $2,100 or higher compared to the spiritual needs when spiritual needs were largely or completely supported. So like you, Shelley, I'm a bit of a nerd with this kind of work. So I just dropped that $2,100 number into the US inflation calculator, and it comes out to be about $2,560 now. So a little bit higher. I thought that number would be higher with that, but that is what you're seeing representationally on the left in the table. And if you've not taken a course like Research Literacy 101, please do, or 102. We'd love to have you be there because one of my professors, I don't know about you, Shelley, said, when you open up a paper, always kind of go to the middle of it. And if they have a table, it should hopefully tell a little bit of the story of, or maybe a lot of the story of what's going on there. And I think this particular image, this figure, does do that. And it has implications. And I think, as you had mentioned earlier, the kind of thing that hospital administrators like to pay attention to. Another study that used some big data, this group of 3,585 US hospitals with a team looked at by Kevin Flannelly group in 2012. So getting a little bit older, but this is still such an important study, and I don't think it's been replicated. So they took some big data, did some analyses, adjusted for important factors, and overall they found that hospitals with chaplaincy services had higher levels of patient enrollment in hospice care. On to you, Shelley.
Great, we're at number 11, replicating numbers here, duplicating them, something. So spiritual care is especially important for family members of patients with serious illness. So studies of families whose loved one died in an ICU find a high proportion with serious emotional distress in the subsequent months. We're talking about things like post-traumatic stress disorder, between 14% to 35% may suffer from PTSD, up to 20% experienced depression or felt depressed, and 46% may have complicated grief. These findings are from two studies, Anderson and colleagues, 2008, and Grease et al., 2010. Poor communication about treatment decisions may be a factor that contributes to this distress. And so communicating around treatment decisions with the healthcare team, this is a role that chaplains can play, and more work is being done around that topic. In light of this, the findings from 2 studies about chaplain care in the ICU context are important. Data from the first study came from 356 family members whose loved one had died in one of 10 ICUs in the Seattle area. This study of family satisfaction with ICU care, it did include an item about satisfaction with spiritual care in that setting. So 40% of the respondents rated chaplain care as excellent, and an additional 25% rated it as very good. So that's about 2/3 giving high marks to the chaplaincy care that they received. Among these families, higher satisfaction with spiritual care was strongly associated with higher satisfaction with their ICU care overall. In the second study, you can see the table shown here. The investigators surveyed 275 family members whose loved one died in an ICU at Harborview Medical Center up in the Pacific Northwest in Seattle. These investigators also collected data from the hospital chaplains about the care that they provided to patients and families in the ICU. And their analysis revealed that greater levels of spiritual care provided were associated with higher levels of overall satisfaction with ICU care. In addition, greater spiritual care was associated with higher levels of satisfaction with treatment decision-making in the ICU. So you'll note that decision-making is the first row in the table there with a corresponding p-value of 0.001 for those looking at the statistics there, signifying the strength of that association. So Paul, thanks for putting these excerpts of tables so that we can whet our appetites on the statistics, especially those p-values. Handing it back to you.
As you know, Shelley, I had a little help with which tables were selected. So again, huge thanks to George for highlighting this really important content. So here we are. I don't think there's a baker's dozen for chaplains. Doing research, I just think a dozen is a dozen. So moving on. So number 12, chaplains help patients, families, and staff with making difficult medical decisions. Here's where I guess the shout out goes to research chaplain colleague, Jeannie Works. Jeannie is a chaplain researcher and ethicist at Northwestern in Chicago and does some really important work, including this 2019 study. I was gonna, if I remembered, I was gonna look it up how many times it was cited, but I think it does get cited a lot. Pretty big number, 463 chaplain respondents that were surveyed about their involvement in helping patients and medical colleagues with medical decision-making. Nearly 2 in 5 often or frequently integrated into the healthcare team discussions regarding medical decisions. So from the information from this survey, Jeannie and her team developed a model of chaplaincy involvement in that shared decision-making. To parse out this table would probably be best to have Jeannie here with us. It would probably take a little bit of time, but we'd invite you again to the highlights document that's available to you and or to return to the slides that will also be available or the YouTube video. Jeannie stays involved in decision-making and together in a partnership with Karen Pujalis, who's also in the Chicago area, they developed a resource called Chaplains as Partners in Medical Decision-Making. You can get it from your favorite online bookseller or perhaps even at a local bookstore. They worked quite hard on putting together a collection of 9 case studies that illustrates the diverse context in which chaplains assist patients and families and their healthcare colleagues in making these decisions. So if you like stories, if you like case studies, great place to read about those outcomes and that involvement. 13, lucky you, Shelley.
13 is my lucky number. So chaplains are an integral part of the pediatric healthcare environment as well, providing coping and decision-making support to both parents and children. Next slide, Paul. So religion and spirituality play an important role for parents of children with serious illness. This includes helping these parents cope and find meaning in their child's illness and in making difficult medical decisions, as Paul was referencing in lucky number 12. So in a recent study, investigators interviewed 24 parents who had made significant medical decisions. They found that the parents drew on guidance from both these internal religious and spiritual resources, as well as what they defined as external resources. Some of the examples of internal resources include making decisions by surrendering medical decision-making agency to the divine, being guided by beliefs in the afterlife, and or making their decision in partnership with the divine. These external resources included receiving counsel from spiritual communities or believing that God worked through the medical team. God was present in the medical team. They concluded parents use religion and spirituality to make medical decisions for their children, and many consider the chaplain to be part of the medical team. This is important, not separate from the medical team, not a supplement to the medical team, but part of the medical team. On to another study. You can see some of the results in the table to the left. 74 parents who had received chaplain visits during their child's hospitalization, majority of those in the pediatric ICU or neonatal ICU, described their experience with and views about the chaplains that they had encountered, this Donahue and team. Parents reported that chaplains provided family support and comfort, as well as help with medical decision-making, medical terminology, and advocacy. Chaplains helped most parents maintain hope and reduce stress. You can see both of those at 83% of respondents. And most parents, about 2/3, felt that chaplain care increased their satisfaction with hospital care overall. So again, this is sort of mirroring some of what we were hearing in some of these earlier highlights. On to you, Paul, for number 14.
Number 14. I think we would be remiss if somehow these highlights didn't address in some aspects what we've encountered over the last, I guess now approaching almost 2 years. So mention here of COVID, and we know how chaplains really entered into this space. So this is a photo showing Rabbi Weiner at Cedars-Sinai in LA in a program that they led and innovated called Code Calm. But the highlight here, I'll just go ahead and read it, is during the COVID-19 pandemic, chaplains creatively responded to support patients, their loved ones, and their healthcare colleagues. And if you want to check out what Rabbi Weiner and team did at Cedars-Sinai, there's that source available to you. So some folks jumped on the data. You'll hear a little bit more a little bit later in these slides as we get close to the last few here. Dr. Jung Kwok, a professor down at the University of Texas at Austin, and a team did some survey work with chaplains. 236 was the sample size, and they worked to describe the changes that chaplains encountered as a result of the pandemic. And 3 large themes emerged and some sub-themes there as well. And among them, as you can see here in the red, they identified that more than half of the chaplains that were part of the study talked about their increased use of telechaplaincy. I'm guessing who's ever tuning into this webinar might be nodding their heads and be in agreement with that. I'm not sure that's going to exactly go away, but others will be collecting that data, I'm sure. And then near the bottom here, the last row that describes the data, chaplains indicated that they were also increasing their support of healthcare colleagues to the tune of 56%. And then this really cool study, I'm glad Georgie called this one out, that comes from the Johns Hopkins world, led by Tracy and team. And it kind of led off with this narrative that a medical intensive care unit provider in taking care and supporting COVID patients had stated that all the patients are intubated and sedated, and there's no family at the bedside being able to tell me their story. So the folks there got to work and developed a protocol where they'd call family of these patients and then record a brief interview. The content of that interview includes sharing a description of the patient, words that the family member might say to the patient if they were present, and what they thought as the family members, the patient would want the medical team to know about them. So certainly not a healthcare directive, but certainly this is one of those, this something is a whole lot better than nothing. And that these interviews were edited down to no more than 2 minutes, posted on a secure server, and then uploaded as a link onto the patient's electronic medical record. And I'm excited to note that a research protocol on this report is underway. 15, Shelley.
All right, so care with ICU patients. On to the next slide. Chaplains have developed and tested interventions for use with ICU patients and their loved ones. And before we go on to the next slide, this is our chaplain colleague, Joel Burning, who is at New York Presbyterian, utilizing this spiritual care communication board that can be so helpful. I've used it myself. My colleagues here at IU Health have used it, and I find it very, very helpful, practical resource. Next slide. So being intubated but alert while in the ICU can make communication difficult and lead to anxiety and distress. And as I mentioned, our chaplain colleague, Joel Burning, and his colleagues created this awesome communication board to help these patients share their spiritual needs and assess for spiritual distress. You can read his initial study from 2016. It was a pilot study with 25 patients, and they found that use of this chaplain communication board during visits was associated with decreases in patient anxiety. And in post-ICU interviews with 28 patients, 81% reported chaplain care with a communication board helped. They felt more capable of dealing with their hospitalization. A second resource for intervention, providing chaplaincy care in an ICU setting, comes from my own setting, IU Health here in Indianapolis, and that's the SKY framework, because research suggests that religion and spirituality are important not only to ICU patients, but also to their family members, especially when they're making difficult medical decisions. But these needs often go unaddressed. And so to remedy this, chaplains and other colleagues at IU Health developed the Spiritual Care Assessment and Intervention Framework, SCAI. Locally here, we call it the SKY Framework. The SKY Framework is a chaplain-delivered, reproducible spiritual care intervention framework. It includes the chaplain's proactive contact with the family, scheduled visits delivered either by phone or at bedside, there's some flexibility there, and a semi-structured approach to assessment and intervention. So now the team has reported data from a study of 25 surrogates, all agreed that they felt supported by the chaplains and agreed or strongly agreed that they would recommend this chaplain support to other families. So far, there's been a follow-up study, and SKY's also been tested in a randomized controlled trial of 192 ICU family members. The analyses are underway with results to be released soon. If you are interested in this SKY framework, it can be accessed on the Daniel F. Evans Center for Spiritual and Religious Values in Healthcare through IU Health. That's the Evans Center for Spiritual and Religious Values in Healthcare. You can put that in the chat too if we need to. Paul, back to you for number 16.
Number 16, and I think, Shelley, time is on our side here. Yes, it is. All right, so Kate Peterman, just south of me here in Rochester, noteworthy to mention that I'm so glad Kate had spent so much of her professional life in Rochester. She is a Canadian, and I like to talk about her work and the exact text here. Let me read that. An important intervention developed by a chaplain helps patients with serious illness review their spiritual life journey. All right, so Kate Peterman, and friends, if you're not familiar with Hear My Voice, I would invite you to get a little more acquainted, but here's just a snapshot for you. To your left is a table that involves some of the content and some of the semi-structured interview questions that are importantly a part of the studies, and there have been several that have been emerged from this Hear My Voice intervention. And a lot of us chaplains talk about life review in our progress notes or in our flow sheet documentation. And then there's the actual evidence-based, research-informed interventions like this. And what's so neat about this one is it was developed by a chaplain with a PhD in doing this kind of research work. But there's other really good life review interventions out there that have also been tested by evidence, like meaning-centered therapy by Breitbart and team, and dignity therapy by Harji Chachanoff and team. But this is designed by a chaplain for chaplains. So this is kind of what makes this really neat, and the important outcomes that have emerged from that, including, I'll just mention a little, I guess, about what happens in case you're not familiar with it. It's given to patients or support persons opportunity to review lives. As I mentioned, it has this interview done by a board certified chaplain. and it can become this personal spiritual legacy document, becoming a keepsake either for the patient themselves or to share with their loved ones. As I mentioned, some of those questions are off to the left in the table. And then here in this last paragraph, I just want to mention, especially here, that some of the quantitative measures that they use, that they've also been able to report that positive changes have occurred in the quality of life of people who've experienced this, their emotional well-being, and the spiritual well-being that have experienced this intervention, as I mentioned. On to you, Shelley.
We talked a little bit about religious and spiritual struggle earlier, and now we're coming back around to talk about some of those interventions that specifically address religious and spiritual struggle. So that was back from highlight number 5, where we talked about this strong and consistent body of evidence about the potential harmful effects of religious and spiritual struggle. This includes evidence of poor adherence to recommended treatment for their children among parents of children with cystic fibrosis who report religious and spiritual struggles. So we are here in Ohio joining Daniel Grossme, who is pediatric chaplain and now researcher. So chaplain researcher and his colleagues have developed an intervention guide spiritual struggles with cystic fibrosis and cystic fibrosis to address religious and spiritual struggles among parents of children with CF. So the team is in the early stages of developing and testing this intervention. So the aims really are to describe the feasibility of the intervention and its acceptability to parents and to the chaplains who delivered it. So at this stage in this study, they wouldn't so much be concerned about the outcomes of the intervention, but really looking to see if chaplains are comfortable delivering it within the frameworks that chaplains utilize, and also how parents receive it. So far, 18 parents of children with CF who screened positive for religious and spiritual struggles were randomly assigned to receive the intervention or to receive CF education for an equivalent amount of time. The guide was delivered in 3 phone interviews, about 30 minutes each, approximately 2 weeks apart. So you're seeing this sort of semi-structured approach and timeline again. The control activity followed a similar pattern. So each guide conversation addressed a different domain that was either intrapersonal, interpersonal, and divine struggle. And the team so far has found that the intervention was feasible and acceptable for both groups, that they were interested in the parents and the chaplains. So next, testing the efficacy of the intervention. That's not a study aim for these early stages, but there was evidence that this intervention reduced parents' religious and spiritual struggles. So what a great finding this early in this project. These findings do support further work to develop and test this guide to be used in pediatric settings with parents of children with cystic fibrosis. Back to you, Paul.
All right, staying with this intervention theme, as you mentioned, and staying also with some spiritual struggles, I want to highlight, again, some work of really important researchers like Dr. Irene Harris. So this one is about chaplains who use building spiritual strengths as an intervention to provide care for veterans and others with post-traumatic stress disorder. So folks, there is an alphabet soup on this, necessarily on this slide, that just can't be avoided. So I just want to cover it here a little bit. And I think whenever you see a figure with numbers that go up and down to such a degree, I think it's important to really pay attention to that. So I'm going to kind of unpack some of this in this slide again, or in the highlights. So the research suggests that religious spiritual struggle can be associated with more severe and prolonged PTSD. As I mentioned, Dr. Harris and team have developed this BSS model, which is a manualized spiritually integrated group therapy designed to reduce symptoms by facilitating the resolution of religious spiritual struggle. It's an 8-session intervention to be accessible and respectable for all people, whether you're Hindu, Catholic, or no identified faith. It can be led by chaplains or other mental health professionals. In a randomized controlled trial involving 138 participants that were randomly assigned to either BSS or present-centered group therapy, as you can see, PCGT. To your left on that figure is that CAPS, this clinician-administered PTSD scale. And they found that building spiritual strengths was as effective as PCGT in reducing those clinician-rated PTSD symptoms overall. And they additionally found here that there's a significant reduction in the defined struggle for the building spiritual strengths that was not present in the PCGT intervention with those participants. All right, Shelley, your last one, I guess.
Yeah, it is. Number 19. So we talked a little bit about chaplaincy during times of COVID, which has, felt ongoing. And one of the things that chaplains have learned more about is telechaplaincy during this time. So spiritual care for outpatients and the use of telechaplaincy are both important areas of growth. This growth had begun before March of 2020, but certainly we have utilized those findings, which have become a lot more pertinent during recent situations of care. So chaplains have been providing spiritual care in the outpatient context for at least several decades. Citation by Stephen King and colleagues from the Pacific Northwest. But recent years have seen increased efforts to routinely offer outpatient spiritual care frequently in oncology clinics. And I don't know about you, but more and more inpatient care, my system is trying to move to outpatient care when possible. In some cases, outpatient spiritual care has been offered in person, but this is an area where telechaplaincy really is growing. So we can look here at an early report of telephone-based spiritual care for cancer outpatients, and that comes from researcher Petra Sprick at Levine Cancer Institute in North Carolina. In this clinic, several questions were used to screen, and you see those questions in the chart to your left. Of 700 or more patients who were seen during the study, 30%, or about a third, reported some spiritual concerns. And the chaplains in the study attempted to call each of these patients and offered spiritual care to them by phone to just about half. And in the table to the left, among those who completed a survey about their conversation with the chaplain, 83%, 8 in 10, a little bit more than that, reported that the chaplain responded very well to their spiritual and emotional concerns. And you see that Paul helpfully turned that 83% to an orangish color there in our table. Lastly, here from IU Health, again, I'm going to talk about that SKY framework, which in addition to being used with ICU family members, has also been used with outpatient cancer patients. There's a study that was just published this year with 24 outpatients with stage 4 cancer and their family caregivers. More than 80% of the patients and caregivers reported that they would recommend these sessions to a family member or a friend. Significant improvements in patients' spiritual well-being after they received this SKY intervention. Paul, you get to wrap us up with number 20.
Number 20, and folks, I chose a rapids photo because these have been some rough waters for us the last almost 2 years with COVID. So this one is about chaplains providing support for their healthcare colleagues, especially being mindful of this pandemic, but hopefully beyond that and even before that. Feeling their work as a calling is associated with greater resilience and satisfaction for healthcare professionals. And I just picked this as a screenshot because I think the lead author comes out of Minnesota, but it's a pretty amazing group because this study done here during COVID found nationally that up to 50% of people had burnout, up to 40% had notable anxiety, depression. So putting some numbers to what we know is some really tough times for us. So chaplains kind of worldwide did this really cool survey and got some papers out of this, including one from our Transforming Chaplaincy research colleague and manager down at the Mayo Clinic in Jacksonville, Biba Tata, who went to school where I did at the University of Minnesota, Sky Uma. 84% friends reported that they had been asked to provide more care for staff. To me, is an important number to pay attention to, and please check out Biba and team's paper for more data from that study. But we also want to mention, and this really important work that comes from Yeager and team before 2017, with a pretty sizable survey involving U.S. physicians, where they assessed physicians' sense of work as calling as well as their burnout. I have to believe this number of burnout will probably have gone up were they to do this again. But what's really cool is that their sense of calling, the sense of feeling my work makes the world a better place, was up to 91%, and that this was a protective factor with people experiencing burnout. there's that great quote here that reflects that as well. For the sake of time, I'm going to move on here to the end. And friends, that is number 20. I so appreciate that you tuned in. Shelley and I both would love to have you be in touch with us. This is now a time for us for questions, and I'm going to put up that last slide, which invites you to consider please join us for our remainder of the webinars this week for Spiritual Care Week. You can find out more information via Twitter or on transformingchaplaincy.org. Question-wise, Shelley, I don't know if you can see them, or Andy, if any have come in.
Yeah, I've got one queued up for us. So one of the questions that came in, I wonder how we live up to these expectations when we are not staffed in a way to meet with patients at least once and rarely more than once. I'm grateful for the research and hopes that it may promote further chaplains being hired.
You got that one, Shelley?
I'll say that one of my tasks during COVID, actually, with chaplains being asked to do more staff support in addition to patient care and these virtual visits with families, is, you know, how do we know what staffing models there are and what evidence there is for how many chaplains we need to be able to cover all that we're being asked to do? Now that chaplains are being recognized for their skills and care in these other areas. And what I learned is there is sort of sparse literature around staffing models. This is an area where there's opportunity for more evidence, more care. And I think, you know, it might be helpful to listen to one of these webinars later in the week from one of the top US hospitals. I believe that's on Wednesday, to tell us about some of their practices, because even if we don't have a strong evidence base yet, we can also turn to colleagues for their best practices. Any thoughts to add on that one, Paul?
You covered it. I think you did quite well with responding to that, and I'm guessing that could be a webinar all into itself.
It really could be. We could learn a lot from more data there.
Yeah. So I can't remember, George, were you going to join us here at the end as well? I don't know if there are any more questions to take.
There is one more question. So from the discussion so far, one can appreciate that both religious and spiritual care has a place in the healing and recovery of patients who are terminally ill. My question is, which of the two is of paramount importance? And Paul, I'm going to pitch that one to you since I took the last one.
So you juxtapose those for me one more time? I mean,
Yeah, so appreciate that both religious and spiritual care has a place in the healing and recovery of patients who are terminally ill. Which of the two? I'm guessing that the question is about religious care or spiritual care is of paramount importance.
Like you, Shelley, I mean, stuff gets us ramped up and keeps us up, and I appreciate the question. There are people like me who like to try to tease out religious struggle and spiritual struggle or spiritual distress, and I don't think there's a clear answer. As we know, a lot of people will put the construct of religiosity within spirituality. Some are more like, no, it can't be within it. It has to be kind of next to it in a conceptual model. I don't think we have enough data to really respond to this really good question in a clear way, but that it is evident, I think, on our teams, at least on the palliative care team that I was on for 10 years, oftentimes when people would refer to spiritual distress, they might have meant religious struggle. So I think the specificity of what we do in our day-to-day practice related to knowing that there is evidence that informs how important this is, especially with people with advanced cancer. And thankfully, hopefully, there's beginning to be more conversation about other ways in which people are in end-of-life nephrology, liver failure, so that it's going to move beyond advanced cancer as well. And I'm guessing, Shelley, we are pretty much out of time. So I want to thanks to everybody who tuned in and for the work that you do and paying attention to the data that's out there that really supports our work, and please contribute to that. Please join our networks. Huge thanks to Andy. Anything, and of course, George, anything for you, Shelley?
Thank you so much for this opportunity. It's great to be here with you, Paul, and have these 20 highlights compiled that we can share with our chaplaincy colleagues and with interdisciplinary professionals in our healthcare setting, with executives, leaders. This is just a phenomenal resource, and I'm happy to be part of it. Thank you for the invitation.
Yes, thank you. All right, take care, everybody.
Thanks, everybody.
You
did
have
great.
a great Spiritual Care Week.